Alright guys, let's look at interventions for peptic ulcer disease. A lot of times the nursing interventions and medical interventions for peptic ulcer disease are determining what the cause and what the irritations are in order to keep the patients from having increased difficulty. Dyspepsia is the most commonly reported symptom associated with peptic ulcer disease. It's usually described as sharp and burning and a gnawing pain. Now remember, if it's a gastric ulcer, food upsets it, but a duodenal ulcer sometimes will if they will find relief with food. It's very easy to get these two different types of ulcers confused. So look at table 55-2 to differentiate between the two types of ulcers. Okay. When people have a bleeding ulcer, two of the things that nursing needs to do is monitor for signs and symptoms of dehydration, and to make sure you're taking orthostatic blood pressures to look for symptomatic anemia. Just like with our gastritis, we need to make sure and ask about the psychosocial aspects of dealing with a peptic ulcer on the patient, their lifestyle, occupation, family, social, and leisure activities. Someone may really enjoy their high stress job, or not eating the greatest of foods, or maybe they're one of the, I took care of a man several times who had history of bleeding ulcers when I worked in ICU. He was always coming to us because he would continue to work even though he knew he was having his ulcer was bleeding. He would have these horrible stools, and he wouldn't come in until he passed out. The scary thing is he was a truck driver, and he said, I one of the statements he said to me one time that really makes me hone in a lot on our psychosocial impact on patients is he said, I'm a truck driver. I love being a truck driver. I love being out on the road. It's just me and my dog, and we're happy. We don't have to deal with people. Sounds like a good life. Anyway, he said, but I eat fast food all the time, and I eat a lot of it, and not exactly don't have anywhere to cook. So when we discovered this, we talked with the dietitian, and we were able to talk to him about different places where he could get foods that were not going to be as acidic and fatty to help with his ulcer. And then we talked with the doctor, and we got him on a higher dose of his proton pump inhibitor. And I never saw him again, and so I'm hoping that means that he did well. But we were able to talk with the dietitian, and again, the dietitian was willing to meet the patient where they were. Okay, yes, we should all eat a vegan diet and run 20 miles a day, but that's not everybody's lifestyle. And if it's yours, I'm very proud of you. If you ever want to just go waddling with an old lady, let me know. But, we have to, as healthcare providers and nurses, meet the patients where they are. We can't expect them to go from 0 to 100. But I'll get off that soapbox. Okay? So other interventions is we want to heal the ulcerations that are present. And really, you're looking at the same type of medications that are used for gastritis. Okay? Alrighty then. So we want to make sure that we are, let's see. We want to make sure that the patients look at what their trigger foods are. Make sure that you read the action alerts on 112 or 1112 and 1113. It talks a lot about sufficient antacids, and it talks about teaching the patients with peptic ulcer disease to avoid substances that increase their gastric acid secretions. And again, these are things that I talked about with the gentleman that we were caring for. And then remember, just like with gastritis, they don't want to eat for 2 to 3 hours before bedtime. And I really want you to look at when you eat your last meal and when you go to bed, and how that really could impact someone's life. And not just on a Monday through Friday. Look at it on the different days of the week. Because that's a big deal. I mean, 3 hours, but talking with nothing on there. Sorry, guys, the squirrels got in my head. Basically, they are not to eat at least 2 to 3 hours before bed. And remember, I want you to look at that and the impact to your life and ignore me just mumbling before. Also, make sure that you look at the action alert on page 1113, where to teach the patients with peptic ulcer disease to seek immediate medical attention if they're having any of these um, symptoms. Just like my friend, the truck driver, who didn't, he had sudden, sharp, persistent, severe epigastric pain. He had bloody or black stools, and he also would have coffee ground looking vomiting. Now, of course, bloody vomiting is when the blood is fresh. Coffee ground is when it has been in the stomach acids longer. Um, but again, that these are important for our patients, okay? It's important for us to realize when we have a patient who has a bleeding peptic ulcer. I've had a lot of questions about priority nursing care. Like when I say pain is a priority, pain is a priority, but it doesn't matter how much pain you're in if you don't have an airway. Okay. And I don't mean to be a smarty pants about that, but it's just the truth. We always look at airway first. We have to maintain life before we can maintain other things. Yes, pain is very important. Yes, a lot of times pain is essential. Um, but we always have to have airway and oxygenation circulation first. Um, but with these patients, remember that you want to make sure that if they are bleeding, that they are hemodynamically stable. Hey guys, I've skipped ahead to home care. So when these patients go home for recovery, especially if they've had a hemorrhagic event, sometimes they'll need home health care to help to visit to manage their signs and their symptoms. Um, Patient education is a huge part of teaching with patients with peptic ulcer disease so that they do not have recurrent bleeding. You want to teach the patients how to recognize new complications and what to do, especially that abdominal pain, nausea, vomiting, black tarry stools. This is all very important. You also want to make sure that you look at the home care assessment for the patient in chart 55-5 that will help. This is what the home health care nurse may do to look at if the patient is caring for themselves adequately at home. Okay. Um, so these are the big things that you would need to do as far as home care. You'd need to make sure that you're teaching them about their medication regimens. That's very important as well. Okay. Um, so we want to make sure that the patients know what they need to go home, make sure that they are well aware of the signs of peptic ulcer bleeding. And most of these patients know it. They know what causes their bleeding, and some of them choose not to come in as quickly as they should. Some come in right away. So it really just depends. We've already talked a lot about complications with ulcers, but this slide just kind of summarizes it for you. We didn't talk a lot about pyloric obstruction. This is when the pleuris is actually occluded. It can be caused from scarring, inflammation, or edema. Signs and symptoms are nausea, vomiting, and abdominal bloating. These patients can have metabolic alkalosis due to the hypokalemia. Okay, but that's with a pyloric obstruction. I'm going to talk very briefly about an upper GI bleed because technically this is a critical care um, scenario, but so often these patients are in on our medical floors being treated for their peptic ulcer disease because they've had a bleed, but it's not bleeding right now. They have the black tarry stools. They're in for their EGD. They all of a sudden go to the bathroom and start vomiting up copious amounts of blood. Yes, you're going to call the rapid response team. Yes, you're going to get those people involved very quickly. But what do we need to do, or what's going to happen to your patient? Because a lot of times, as the med-surg nurse, yes, you have your patient who's all of a sudden vomiting up frank blood, or they go to the bathroom and they have this horrible amount of excessive amounts of bloody diarrhea. which is called a port wine stool, but usually it's vomiting. With the upper GI bleed, you're going to see that upper GI bleed, you're going to see vomiting. And it's scary to see somebody all of a sudden start vomiting blood. Of course, you're going to call the rapid response team, but a lot of times the rapid response team comes in and starts doing their thing, and you're left with the family member who's sitting there going, oh my goodness, not only is it a terrifying thing for them to see, but they want to know what's going to happen. And so I think it's important for us, even as med-surg nurses, to know what's going to happen when the patient's, when we do call that rapid response team and the patient moves up into critical care. They're going to do gastric lavage, usually with cool water to try to stop the bleeding. They generally will go for EEG for intervention. Sometimes if the bleeding is controlled quickly, they will come back to a med-surg floor. So I do want you to look at the care of the patient with coming back from the GED. Maybe I need one. An EGD briefly, and that is on page, one moment please. It's on a page. There we go. It's the action alert on page 114. So do take a look at that. Mainly with the upper GI bleed, the big thing is to stop the bleeding. For our intents purposes, if we were on a med-surg floor and our patient started vomiting up frank blood, we would call a rapid response team and hope that they would help us place the NG tube and start gastric lavage, but this patient would be moved to critical care. I'm going to talk very briefly about dumping syndrome. It's listed on page 117. And the reason that dumping syndrome is in this section is because the Roux-en-Y, which is the procedure better known as gastric bypass, it's called a Roux-en-Y. And a Roux-en-Y was done for years. I mean, when I say years, I left critical care in 2003. And we were doing this procedure then, and it's for peptic ulcer disease, and it's because they remove the majority of the stomach to remove the ulcerative point. The problem with this post-gastric removal of the stomach is that they will end up with dumping syndrome, where no matter what they eat, it just rapidly goes into the small intestine, causing shifts of fluid and causing abdominal distension, especially if they don't eat correctly. There's a specific diet that these patients are to follow on page 118. It talks about food and meat substitutes and what they need to do to be more cautious with it. It talks about dumping syndrome is managed by nutritional changes, including decreasing the amount of food taken in at one time and eliminating liquids ingested with meals. So this is where you'll see these patients come in, especially people who have had gastric bypass surgery and who do not follow the diet regimen that is given to them. And hats off to anyone who can follow the diet regimen given to someone who has gastric bypass. As you guys can tell from your instructor, I am a morbidly obese woman who desperately needs to lose weight. I would never have gastric bypass because I would never be able to follow the diet. And because this is what happens when patients do not follow the diet. They end up with this called dumping syndrome, where you have large amounts of food going into the small intestine, causing both the shifts of fluid into the gut and severe abdominal distension. These people are miserable. I've seen this twice. I don't work in an area where I would see this often. Where I have seen it is where people have had gastric bypass and are now pregnant. And so they think, well, they're pregnant, they can eat what they want, but they've had gastric bypass, and so they can't eat what they want. And they end up with dumping syndrome on top of being, I think you guys are, y'all are all through this part of maternity where, they're finished with that first trimester where they can't eat anything. So now they eat too much, they eat the wrong foods, and they end up with dumping syndrome. So that's my opinion on gastric bypass, just my opinion. But anyway, for me personally, I know people who have had it and have done well. But for us, for dumping syndrome, just know that what it's caused from and the treatment is small frequent meals and special dietary considerations. That's it, guys.